Bună seara și bine v-am găsit la un nou eveniment organizat sub egida Pășind pe urmele giganților, un eveniment organizat de către Universitatea de Medicină și Farmacie Victor Babeș din Timișoara. În această seară avem un invitat special, un invitat pe care doamna profesor Danina Muntean a reușit să îl aducă alături de noi și să împărtășească o mulțime de informații frumoase. Așadar, vă rugăm, doamna profesor, să ne spuneți despre ce este vorba, dar înainte de a începe, doresc să reamintesc participanților noștri că acest webinar se va desfășura în limba engleză, iar întrebările pe care le vor avea le vor putea adresa atât în zona de Q&A a Zoom-ului, cât și live în zona de comment pe YouTube. Așadar, vă rugăm, doamna profesor.
Bună seara tuturor! Mulțumesc pentru invitație. Într-adevăr, este o mare plăcere și onoare deopotrivă pentru mine să îl prezint astăzi pe domnul profesor Denis Angoulvant, cu care ne cunoaștem de, într-adevăr, 20 de ani. Este ca un Dumas, 20 ans après. Domnul profesor înțelege românește. Nu, desigur, nu va ține prezentarea în română și eu voi continua introducerea dumnealui în limba engleză. Nu înainte de a spune că cineva m-a întrebat cum ai defini un gigant. Ceea ce mi-a pus o problemă și mi-am adus aminte că Picasso a scris The meaning of life is to find your gift. The purpose of life is to give it away. Cred că Denis este un gigant pentru că și-a găsit scopul vieții, adică cel de a fi deopotrivă un medic și un cercetător, așa numitul physician researcher, despre care se discută și o să vă convingă el însuși despre acest lucru. So it's my great pleasure to introduce today Professor Denis Angoulvant, who is Professor of Cardiovascular Medicine and head of the cardiology clinic at the Trousseau Hospital in France, in Tours. I was thinking to the French Loire because he is coordinator of the Loire Valley Cardiovascular Collaboration, and also he is a deputy director of an important INSERM unit, research unit, dealing with immunity, inflammation, and transplantation. He is currently the president of the scientific committee of the French Federation of Cardiology and past president of the cardiovascular research branch of the French Society of Cardiology. And more important, he's an excellent teacher. He's the vice dean in charge of medical pedagogy at the Faculty of Medicine of the University of Tours. So he will share with us now his huge expertise in the field of ischemia reperfusion injuries. And I have to acknowledge that we met each other when I got a postdoc fellowship in the lab of Professor Michel Ovis, who was coordinating by that time his research activity. But you will see that he was an explorer as well. He joined other laboratories, which is what a true researcher has to do. And I will cut the long story short, and Denis, the floor is yours.
Thank you, Danina. Bună seara toți. I'm delighted to have the opportunity to give this lecture and to be invited by my old friend Danina Muntean. So the title is 20 Years of Protecting the Heart Against Ischemia Reperfusion Injuries. I have no conflict of interest related to this presentation to disclose. So just to see what's going on here, I was a medical student in Paris in the 90s, and then I moved to Lyon to become a resident in cardiology, and I did my early career as a researcher there. And this is where I met Danina when she came for a postdoctorate fellowship. Later on, I did a 2 years fellowship in Toronto, in Canada, in Professor Weisel's laboratory, working on stem cell therapy to regenerate the heart. It's something I will discuss below with you. Then I went back to France and I was promoted full professor of cardiology in Tours in 2011. And in the meantime, we developed a collaboration between our research group and Professor Montean research group in Timișoara Romania, where I was honored to be visiting professor in 2016. So, as you said, I'm a researcher, but I'm a clinician too. And the research I do stems from the clinical situation I face as a cardiologist. I am an interventional cardiologist and an intensivist cardiologist. My playground is the intensive cardiac care unit and the cath lab. And my motto is to go from bedside to bench and then back from bench to bedside for the benefit of our patients. So here's a clinical situation that we often meet in clinical cardiology. It's a patient that's being admitted for acute myocardial infarction. The patient has chest pain. ECG shows elevation of the ST segment in the inferior leads, and the patient is being rushed to the cath lab where we perform coronary angiography and witness complete occlusion of the right coronary artery, as you can see on the slide here. Fortunately, we have many tools to reopen the coronary artery, including early PCI with stent implantation that allows us to restore coronary blood flow in a timely manner. That's the best way to protect patients and to prevent serious adverse outcomes and death. Why do we have to reopen the coronary artery as soon as possible? Well, to reduce infarct size. And we've known for a very long time that infarct size, which means what remains of the heart after myocardial infarction, the part that is not alive, is a major determinant of patients' future outcomes. I mean, the larger the infarct, the worse the outcome. This has been known for years. So the task as clinician first is to prevent patients from having a heart attack. This is our goal in the primary prevention. But when heart attack occurs, the goal is to reduce infarct size to prevent severe outcomes. Now, the main determinant of final infarct size in our patients stems from the area at risk. If the patient, unfortunately, has an occlusion in the proximal area of the artery, there will be a very large part of the myocardium that will suffer from ischemia and may die if there is no timely reperfusion. When the patient is lucky, he or she will occlude the artery in the distal segment and have a smaller infarct. So infarct size relies on the area at risk. This is very important for research. The other part is the ischemia duration. If the occlusion only stands for a few minutes, there will be basically no infarct. The longer the occlusion, the larger the infarct size. Other factors will impact the infarct size. The eventuality of the patients having a collaterality between coronary networks, but this is something you cannot anticipate. So only luck can bring you with a collaterality that will protect part of your heart. And more important, reperfusion, the fact that we are able, clinicians, physicians, emergency medical service, to perform early reperfusion by rushing the patients to the cath lab will reduce mostly ischemia duration and then the extent of myocardial infarction. So reperfusion is cornerstone for acute myocardial infarction. Now, things are somehow complicated, as you know. We know that this graph shows you the dynamic of myocardial necrosis, infarct size, by the time during a myocardial infarction. When the artery is occluded, there is a lack of oxygen and nutrient because the blood doesn't bring it to the heart anymore. So the myocardial tissue starts dying. And if you don't do anything, you will follow the red plot here. And at the end, the whole area at risk will be destroyed and you have a major myocardial infarction. What we do is to reopen the artery with the hope to stop the ischemia and the necrosis process. But what we observe is that part of the myocardium will be destroyed during the reperfusion process at a time when the patient is within medical hands, which is pretty frustrating, isn't it? So reperfusion allows us to reduce infarct size, but at the same time, the infarct size we end up with at the end is larger than what we anticipated by doing timely reperfusion. So there's a way of improvement here. we may be able to reduce this infarct size that happens during the reperfusion time, what we call reperfusion injury. How does reperfusion impact the myocardium? Why do we lose part of the myocardium during reperfusion? Has been extensively investigated for years. There's a bunch of events that happen within the heart at the time of reperfusion. Some of the cells already died during the ischemia. It's too late. There's nothing you can do for those cells. But those cells that are still alive at the early time of reperfusion and that will be destroyed during the minutes and the hours following reperfusion, we may be able to save them. And to do so, we need to understand what happens. There's a lot of events, intracellular events, including calcium overload, ATP release, pH correction, releasing of reactive oxygen species that will have a bunch of effects within the cells, mostly on the bioenergetic part of the cells. And together with those events, you have the part linked to inflammation that I will further develop. What happens when you have such damage within the heart? On the right side of the slide, you can see an echocardiography of the heart 1 week after infarction, with already an enlarged left ventricle and a reduction of the ejection fraction. This is 41%, the normal being 60%. And if the remodeling process continues because of an initial large infarct and an inflammatory response, see 3 months later, LV enlargement is increased, ejection fraction is severely decreased at 23%, and the patient is likely to suffer severe complications, including early death. We want to avoid this in our patients. So myocardial infarction is the most frequent situation for cardiologists where we meet these reperfusion injuries, but they can also occur in other clinical situations, such as heart transplantation, because at the time of heart transplantation, when the heart is retracted from the donor chest, that doesn't need it anymore, unfortunately, and the time it is being shipped to the receiver chest, the heart suffers from ischemia. Although we use tons of maneuver to protect it, you still have ischemia reperfusion that will be added with rejection of an allogenic heart donor. And we have the same process in cardiac surgery, because as you know, in cardiac surgery, often we need to stop the heart to perform the surgery. So there will be, once again, ischemia reperfusion, although it's controlled because it's being done in physician's hands. So what do we do to prevent those reperfusion injuries? In the 1980s, Murray made the first publication showing that he could experimentally reduce these reperfusion injuries by performing, as you can see on the slide here, short ischemia reperfusion, short period of ischemia reperfusion. It was a dog model of ischemia reperfusion. So these small sets of sequences of ischemic perfusion are being performed before the large ischemia that prevents that is before reperfusion that will induce cardiac necrosis. Doing this ischemic preconditioning maneuver, he could dramatically reduce the infarct size at the end of the experiment. So it was the first time we could reduce reperfusion injuries with ischemic preconditioning. It's very interesting, but as you may notice, very hard to translate into the clinic because patients don't often show up in the cath lab an hour before having a heart attack. So we could study, we could try to figure out what happens, but we couldn't translate it into clinical practice. Later on, other kinds of ischemic conditioning were investigated and unveiled. The remote ischemic conditioning that I will discuss later on. In this set of experiment, the ischemic conditioning was performed in another part of the body. For example, in patients, you can use a handcuff that is usually used to measure blood pressure, crush the artery to induce ischemia of the forearm. And by inducing ischemia of the forearm, there will be some signals that are being sent to the heart to protect the heart from the ischemia reperfusion assault. The conditioning could be performed before or during the ischemia of the heart. That was shown first by Karin Prisklenk in Circulation 1993. But the true event was this publication of 2003 by the group of Vincent Johansen in the United States, showing that performing ischemic post-conditioning, that I will detail in the next slide, could really decrease infarct size. And this is much more interesting for translational research, because this ischemic post-conditioning, we can do it when we have patients admitted for an acute myocardial infarction. So that's how it works. Usually when a patient arrives for a coronary occlusion, we implant a stent by PCI, deliver the stent, and we have blood flow restoration. That's the standard of care for a coronary occlusion at the acute phase of myocardial infarction. We do this every day, right? Now, ischemic post-conditioning is slightly different. You still have the stent implantation, ideally direct stenting. It works much better. It avoids sending small pieces of thrombosis in the distal artery. After doing the stent implantation, we retract the balloon above the stent, still in the artery. It's retracted, it's deflated, so blood flow has been restored, same as in the standard of care. But then we will re-inflate the balloon above the stent to re-occlude the artery for 1 minute. This is the ischemic post-conditioning. We induce ischemia just for 1 minute, then we deflate the balloon for another minute, restoring blood flow. And this ischemia reperfusion sequence that is controlled by the physician will be repeated 4 times. 4 times, 1 minute of ischemia, 1 minute of reperfusion, before removing the catheter and leaving the blood flow restoration as in the standard of care. This procedure is directly was directly set from the animal experiments performed before, but we did this in human. I will show you the results. Now, what we knew from all the research from ischemic post-conditioning is that a bunch of signaling pathways are being activated within the patient cells, within cardiomyocytes, by ischemic conditioning and also by several pharmacological agents that we will discuss later. And all this pathway more or less end up by modifying in the mitochondria some key biological process involving the mitochondrial permeability transition pore, the potassium ATP channels. The most famous pathways are the safe pathways with STAT3, the risk pathway with PA3 kinase, AKT, GSK3 beta, and the ENOS PKG pathway. In the mitochondria, the fact that there is ischemia reperfusion, one of the major actors is the MPTP. The MPTP opens up. This is a big channel that is in the inner membrane of the mitochondria. Because of ischemia reperfusion, the MPTP opens widely and releases a bunch of calcium ions within the cytoplasm of the cells. And this burst induces cell death. Other factors are involved in the cell death after ischemic perfusion, such as cytochrome C activation that will activate caspase-3 and cell death. So we try to avoid those events that are the key effectors of cell death at the time of reperfusion. So that's what ischemic preconditioning and postconditioning do. We clearly showed the link between ischemic conditioning and pharmacological conditioning and MPTP desensitization. In those basic science experiments that were performed in our lab in Lyon, where Professor Denis Montaigne joined us for part of those experiments, we clearly showed that preconditioning and postconditioning delayed the release of calcium ions by the MPTP. And we had the same observation when we added cyclosporine A in those mitochondria subjected to ischemia reperfusion. So from all those research that were preclinical research, we had a bunch of data to say that postconditioning can protect the heart from reperfusion through desensitization of the MPTP in cardiac cells. That's the reason why in 2005 we shifted from bench to bedside. See, we had one bedside to bench, try to understand, now bench to bedside. What Michel Ovis, who was our boss in Lyon, did was to perform this clinical trial in which patients that were admitted for acute myocardial infarction were randomized between the standard of care with direct stenting to reopen the artery versus patients being subjected to ischemia reperfusion with ischemic postconditioning, as I showed you before, balloon inflation, balloon deflation 4 times after having reopened the artery. It was a success. The number of patients was low, 30 patients, 15 in each group, but with a surrogate marker of myocardial infarction reduction, that was the release of CK in patients' blood with a repeated blood test within the next 72 hours. We had a clear 36% reduction in the area under the curve of CK release, showing that ischemic postconditioning could reduce infarct size in our patients. So that was the first in-man experiment. Later on, several other studies were performed from our groups and from other groups, which is always good. Science needs to be repeated to be convincing. And a few years later, we did this meta-analysis showing that ischemic postconditioning at the end does reduce myocardial enzyme release at the time of infarction. It was more visible for CK than for troponin, but troponin has a strange pharmacodynamics within the body. And when we investigated infarct size using stronger surrogates, such as SPECT or CMR, there was a trend toward reduction of infarct size, but it was not so convincing. I must admit that the postconditioning, ischemic postconditioning, was later on not as good as we hoped. You had this major clinical trial published in 2017, 1,234 patients randomized between conventional PCI and postconditioning by Engstrom group, and they showed no reduction of infarct size, and more important, no reduction of clinical events. And that's what we want. We want clinical events to be reduced. So the analysis of the data is there was a large heterogeneity of postconditioning procedures. We performed 4 times 1 minute. They performed 4 times 30 seconds. We implanted the stents before doing the postconditioning. They implanted the stents later on. Anyway, it didn't work. And today, ischemic postconditioning is not part of the standard for those patients. Another part that I already mentioned is the remote ischemic conditioning. This, in the preclinical setting, worked pretty well. You can either induce ischemia of the kidney at the time of myocardial infarction. You do ischemic conditioning of the kidney, you protect the heart. You can do it with the liver. It's been done with the guts, with the lung, with the brain. It seemed to work pretty well. The mechanism that were evoked there were probably the release of cytokines and also the activation of the autonomous nervous system. So there was a first in-man trial published in 2010 by Bochter. There's a Danish guy. They performed a remote ischemic conditioning using the handcuff in patients that were rushed to the hospital with acute MI, and they were having thrombolysis in the ambulance. They had some interesting data showing a trend for a reduction of infarct size under SPECT. Now, we performed with my dear friend Fabrice Prunier in Angers a clinical trial in the early 2010. Patients were being admitted for acute MI, and at the time of reperfusion, we performed ischemic remote conditioning of the forearm using a handcuff. The handcuff was put under 200 millimeters of mercury of high pressure for 5 minutes. So this is not nice for the patients, but when you have chest pain, they don't pay attention to what happens to the forearm. Believe me, I've done it in several patients. 5 minutes inflations, 5 minute deflations, and again, the sequence was repeated twice. And we had a pretty interesting 31% reduction in CK-MB area under the curve. That was the surrogate marker of infarct size. It was once again a small size trial to prove our case. Later on, other trials showed interesting results with remote ischemic conditioning, and we did this meta-analysis in 2015. But remote ischemic conditioning has been tested in a bunch of situations: primary PCI, elective PCI, surgery, cardiac surgery for children, for adults, vascular surgery. All in all, there was a trend toward beneficial effect on long-term MACE and long-term all-cause mortality. But we needed more convincing data, and unfortunately, we didn't get them. What we get was a large clinical trial that was performed by the group by Derek Henseloy in London, and they on a large number of patients, almost a little more than 5,000 patients, they showed no beneficial effect of remote ischemic conditioning in patients that had early PCI for myocardial infarction. So once again, when we try to translate into the clinic, we didn't get the success we had in the preclinical or in the phase 2 clinical trial. Nonetheless, you keep trying because you want to progress and save more people. As I mentioned before, cyclosporine has pretty much the same effect as ischemic conditioning on the mitochondria. So we tested cyclosporine at the acute phase of myocardial infarction PCI in patients. They were randomized between cyclosporine and placebo that was injected in the vein at the time of PCI. Again, this was a phase 2 trial, 50 patients, with a pretty interesting result with a significant reduction of CK release and a reduction of infarct size in a subgroup of patients that had early MRI to state infarct size. This paper was the first in man. It was published in the New England Journal of Medicine, but it was a phase 2 trial. So we needed, obviously, a clinical trial with hard endpoints. You want to show that you not only reduce infarct size, but you reduce clinical complications. You reduce mortality in those patients. So it took a few years to set up a larger clinical trial, and it took a few years to find the money to do it because research is costly, especially clinical research in people. And we found a way to set up a phase 3 randomized prospective clinical trial with placebo, comparing cyclosporine to placebo in those patients that were rushed to the hospital for early PCI for acute myocardial infarction. Here, the endpoint was not infarct size. The endpoint was a clinical endpoint, combining all-cause mortality, worsening of heart failure, and LV remodeling. And as you can see on the curves here, we had no effect at all. This is the 1-year follow-up for all those patients. And the follow-up at 3 years is not published yet, but I know the data because we're drafting the manuscript, no change at all. So it was a huge disappointment for the researcher here because all the data we had from preclinical and the phase 2 clinical study did not translate in a phase 3 clinical trial. That's hard, but that's the law of science and of honest science. So recently, Gerd Hirsch, one of our German colleagues, who is a leader in cardioprotection in Europe and the world, did this publication in Nature Review Cardiology, summarizing all the knowledge we have from ischemic conditioning and pharmacologic conditioning. So whatever we tried, we never had any significant clinical benefit in patients that would have allowed those procedures to be translated into the guidelines. Among the drugs that were tested, I mentioned cyclosporine because we did it. Some of our colleagues also did clinical trials with EPO that didn't work. Metoprolol was also tested, but we never have the good results that we were expecting in patients. So far, ischemic and pharmacological conditioning are still under investigation, but no clinical results that would allow us to perform it in routine in our patients. Now, in the early 2000s, there was a new idea that said, okay, we try to protect the heart. At this time, we're still trying, right? And we're still trying now. But some said, maybe we can regenerate the heart. You know that the heart doesn't spontaneously regenerate, or almost not. There is a few background of cardiomyocyte regeneration, but not good enough. Otherwise, I wouldn't be a cardiologist. They wouldn't need us, right? But the idea was to try to regenerate the heart, such as we can regenerate patients' bone marrow with bone marrow transplantation. So there was a few pioneers of cardiac regeneration that started in the late 1990s. And I was sent to Canada to work on cardiac regeneration with Professor Weisels and Professor Renki Lee. So the idea is here, working on animal models, is to induce a myocardial infarction by performing coronary ligation and to inject within the heart cells that are bound to regenerate their heart. We were mostly using stem cells because they have this ability to proliferate and to differentiate into cardiac cells. So we had in France Philippe Ménacher that had been previously publishing good results with skeletal myoblasts, which are the stem cells already dedicated to make muscle, but usually it's peripheral muscle, not heart muscles. Here we tried with mesenchymal stem cells that are supposed to be cells within the bone marrow that are here to sustain and to help hematopoietic stem cells to foster. Mesenchymal stem cells work pretty well. We had in the mice reduction of infarct size, preservation of function, reduction of collagen degradation, and cell apoptosis. We also tried this in a pig model of myocardial infarction by doing pig coronary occlusion with coils and injecting mesenchymal stem cells from human origin, actually in pigs. All those preclinical studies had pretty good results, but as you may know, they have been later tested in clinic in patients in the clinical trials, which I didn't take part of those trials, but we never had any cardiac regeneration. Nonetheless, no cardiac regeneration, but still some kind of cardioprotection, because the data we have here, these data are the data. I mean, we had an improvement of heart in mice or pigs that received the stem cells, although no significant regeneration. So what happens? Well, the idea was that stem cells were cardioprotective. We were most probably inducing cardioprotection by injecting those cells. Now, how do they cardioprotect the heart? This is something then we try to investigate, and we did a bunch of preclinical experiments using cell co-culture and animal models in which we didn't inject the cells, but we inject the supernatant, the culture medium in which the cells had been cultured for days. Cells, when they are being cultured, they release a bunch of growth factors such as FGF, IGF-1, several things. It's endless if you try to measure them all. So we investigated the effect of mesenchymal stem cells supernatant, not the cells, only the supernatant, an ischemia reperfusion model, cellular model, and also an isolated perfused heart on a Langendorf apparatus. And we showed that there was an effect. Mesenchymal stem cells supernatant or conditioned medium reduces the cardiac injury at the time of reperfusion. Through a bunch of growth factor, we use some inhibitor of the PIK3 AKT pathway, such as workmenin or LY294002, and we found that there was an effect, advocating for the activation of the pro-survival pathway that had been long described with ischemic conditioning. So somehow, mesenchymal stem cells seem to be cardioprotective, or at least the supernatant is. Now, it's not easy to use mesenchymal supernatant in patients, I would admit that. But then we shifted toward a new hypothesis, which is that we know that inflammation plays a role in reperfusion injuries. And those mesenchymal stem cells, some of them, such as mesenchymal stem cells from the bone marrow, they have strong immunomodulatory properties. They can avoid rejection. This had been proven in some animal models. So we investigated the inflammation because it's not an easy thing to handle when you talk about inflammation and post-myocardial infarction remodeling. We need a bit of inflammation after myocardial infarction for the heart to heal. If the heart doesn't heal, you may experience severe heart rupture that would lead to death. It has been tested in the 1970s, giving huge corticosteroid doses to patients, and they died from heart rupture. So we need a bit of inflammation, but not too much, because if you have too much inflammation, then you have a lot of remodeling and the heart would enlarge and the ejection fraction will reduce. So the goal here, the new hypothesis was inflammation is a key player. We need it, but not too much. So we need to modulate inflammation. So to do so, cardiologists went back to the bench to study inflammation. So we asked our immunologist colleague to tip us about how does it work. We know that inflammation is the first line of defense against pathogens such as bacteria, virus, fungus. And when those pathogens get into the body, innate immunity through inflammation receptors activate to give a proper response to protect the body against those agents. Well, actually, we have pretty much the same pathway activated when you have what we call sterile inflammation. When the heart dies, a bunch of substance from within the cardiac cells are being released, and some of them are what we call alarmin and ATP is one of them. Those compounds, where they're being released in the patient's body because cardiac cells are dying, they will activate some of those inflammation receptors already known, such as the toll-like receptors, purinergic receptors, RAGE, node-like receptors. And they will activate the inflammation pathway that are pretty much the same as when you have an infection with IL-1 beta, IL-6, and then CRP, and so on. So we hypothesized that ATP being released at the time of cardiac cell death, this might be an interesting target for us to study. We know that ATP and its derivative, ADP, AMP, and adenosine, have a bunch of receptors that you can find pretty much everywhere in people's body, but mostly in cardiac cells and fibroblasts and vascular cells and white blood cells. So in the first set of experiment, because we were dealing with immunologists, we tried to investigate the effect of hypoxia reoxygenation on one of those receptors, the P2Y11 receptors. That was the one we isolated as being of interest in human dendritic cells. You know, dendritic cells, there are these chef d'orchestre, you know, the director of the immunological response. They can choose between pro-inflammatory or anti-inflammatory or medium inflammatory response to any damage within the body, whether it is bacterial activation or sterile inflammation. And in this first interesting experiment that we performed when I started a new research group in Tours, we found out that hypoxia reoxygenation reduces the ability of a dendritic cell to modulate inflammation through repression of P2Y11 receptor when it's activated by ATP. And the actor actually of this repression was HIF1 alpha, a famous actor of hypoxia response, of cellular hypoxia response. Therefore, the hypothesis that P2Y11 could play a role in mediating inflammatory response in dendritic cells emerged, and we kept on studying this receptor. We did a bunch of experiments that I will summarize later, but one of them, the most interesting was this mice model of heterotopic cardiac transplantation. One of our young surgeons did his PhD on this topic. We created a model of heterotopic heart transplantation, and we modulated P2Y11-like receptor using agonists and antagonists that were injected in the mice. And we show that when we activate P2Y11 receptor, we reduce allogenic cardiac transplantation rejection and prolong cardiac graft survival with a reduction of lymphocyte infiltration. So here we have a pathway that could prevent ischemia reperfusion and inflammation, both in our models. Later on, with a collaboration with Professor Denis and group, we did a bunch of experiments to test the effect of P2Y11 activation or inhibition at the time of ischemia reperfusion in cardiomyocytes, and we showed that it increased the viability of cardiomyocytes to activate P2Y11. On cardiac fibroblasts, they play a major role in ischemia reperfusion injury because within the heart, they communicate with white blood cells and with cardiomyocytes. So using a co-culture model, we showed that P2Y11 activation reduces proliferation of cardiofibroblasts that are a big part of what we call fibrosis, and fibrosis is a deleterious phenomenon within the ischemic heart. They also reduce myofibroblast switch, cardiofibroblasts they switch to this new phenotype of myofibroblast, and then they will induce fibrosis. And they also reduce secretion of pro-inflammatory cytokines by the cardiofibroblast. More recently, with Professor Montian and her team, we evaluated the effect on vascular cells. Vascular cells are part of the myocardium. Vascular cells, they play a major role because they're the first the first contact between the blood at the time of reperfusion and the rest of the myocardium. And they also suffer from ischemia. And what we found there is that activating P2Y11 could restore vascular function and reduce hyperplasia of those cells. So all those collaborative work we had with the Professor Montian group in Timișoara, part of them were funded by a French-Romanian collaborative grant called the Programme Ubercurien Brancuș that we had with Dr. Abuel, one of Professor Montian's close collaborators. So as you can see here, we had several very interesting and nice publications and the story of P2Y11. Now, because inflammation seemed an interesting topic, then we went back to bedside. This is a new hypothesis we developed in the last years in France. As I mentioned before, inflammation is a critical part of acute myocardial infarction after reperfusion. But so far today, we don't have any therapeutic recommendation to modulate inflammation. Maybe someday with P2Y11, but we're still on the bench, I must admit. So we hypothesized that colchicine, which is a potent anti-inflammatory drug, may be of interest to reduce this inflammation part at the time of reperfusion in patients. We already had clinical trials showing that giving colchicine to patients with coronary artery disease was beneficial. But in those trials, colchicine was used as an agent to prevent atherosclerosis to foster within the artery. It was given in secondary prevention, so in high-risk patients. But the target here was the vessel. It was the atherosclerotic plaque. It was not the myocardium. So we tested the hypothesis that giving colchicine in patients at the acute phase of myocardial infarction may reduce cardiac dilation, cardiac remodeling, and maybe someday cardiovascular events. So in this study called COVERED-MI, we randomized patients referred for acute ST elevation myocardial infarction in a double-blind prospective controlled trial to an intervention group where they received colchicine, loading dose 2 milligrams in the cath lab with a tablet. There is no intravenous colchicine. It's too dangerous. It's been abandoned 20 years ago. And then the colchicine was continued for 5 days with 0.5 milligram twice a day. And the control group was receiving matching placebo without us, physician, or the patients knowing in which group the patient had been randomized. And for this study, we tested cardiac remodeling through MRI that was performed at day 5, at day 15 to, at 3 months, and at 1 year. You can see here the flow charts of the patients. We had 161 patients in the final analysis. So it was a disappointment. Once again, we found, no significant reduction of infarct size at 5 days. That was a primary endpoint on MRI with the colchicine. We had actually no difference in most of our endpoints, whether they're being clinical endpoints or imaging endpoints. And surprisingly, we had more left ventricular thrombosis in the group receiving colchicine, and we're still investigating this part of the results that came as a surprise for us. Now, so just to mention the COVERED-MI trial, we published it in Circulation at the end of 2021, and we're not pursuing with the colchicine at the acute phase of MI because these results were not encouraging enough to go for a large-scale clinical trial, but maybe it will be re-challenged. So before going to the last slide, I would say I have been trying to follow the path of translational research to prevent myocardial reperfusion injuries. And what I showed you today was my journey in the footsteps of the giants that taught me everything. Those giants are the guys who showed the first time that ischemic conditioning could prevent cardiac damage at the time of reperfusion, that pharmacology conditioning could change something, even though we couldn't transfer this into the clinical setting in patients. It paved the way for more investigations, for new concepts, and a lot of researchers around the world, including us, are still working on it. Then also we had those giants trying to regenerate the heart with cell therapy. It didn't work, but then we found out that we had a way to modulate inflammation with those cells. And now, see, we're working on inflammation, and I'm pretty sure that someday it will translate into the clinic. So my advice would be for a young researcher, especially for clinicians that want to do the basic and translational research, to go back and forth from bedside to bench and from bench to bedside. You can't do anything on your own. So you need to have collaborations that sometimes become friends, such as the experience I had with Professor Denis. You need to collaborate with clinicians, with researchers, and to be at the interface to find new hypotheses and to bring a new experiment that may sometimes help us make new discoveries. So I have to acknowledge that a lot of people were part of my journey. Professor Montian, our research group in Timisoara, we've been collaborating for years now, and I hope we will still be collaborating for years in the future. I was honored to be received at the Victor Babèche University in Timisoara, and I'm always happy to come if needed. I also want to thank my colleagues in Lyon, Professor Michel Oviz and Professor Nathan Mewton, that have been collaborating with for years, and Professor Theodora Bejan-Angoulvant, that not only supported me as a wife and taught me to speak a little bit of Romanian, but also is doing a lot of research with us. She's the one doing all the meta-analysis and the statistical analysis, because she's a professor of clinical pharmacology and also cardiologist. To do the research, we needed money, and we got the money from those collaborative programs I mentioned, also from the Fédération Française de Cardiologie and the cost action. So I'm done now with the presentation. I've seen there's a lot of questions, so I guess we have time now to discuss and answer these questions, and I would be really glad to interact with you.
Thank you very much, Denis. It was a great presentation. And of course, thank you for your collaboration. It is an honor to collaborate with a giant always. And as you see, this is a modest giant. Of course, I'm impressed by the fact that we have already 3 questions. But firstly, I just want to mention this is research about. That is, you are lucky that you have published your negative study, because sometimes negative studies are not published, and this was in circulation. And there is a lot of serendipity in research. I think that the new statins of the century, that are the SGLT2 inhibitors, which were found by serendipity to be active in heart failure, will be a very interesting area to follow, to pursue in the future. And hopefully we can design some experiments together and of course cooperate. And it will be my pleasure to host you back in Timisoara, because we had a PhD in co-tutorship, as you mentioned in that publication. Maria Danila had a very nice thesis and a very nice collaboration, and also under the umbrella of the grant that you run together with Juana, which is my right hand. In fact, I have, as you know, 2 right hands. She's the oldest right hand because she's the mitochondrial girl, and the youngest right hand is Adrian Sturza, which is the endothelial boy. So now, if you would like to answer the questions, you can read them.
Yes, absolutely. So we had a question, say the colleagues, it's Alejandro Bot said, The difference between STEMI and NSTEMI is a sign that the vascular system of myocardium is different from a patient to another. Well, actually, he says, I refer just that unknown vessels in Latin nomenclature of myocardium anatomy. Well, no, actually, the difference between STEMI and NSTEMI is rather the clinical presentation. In STEMI, when you have STEMI at the acute phase of myocardial infarction, usually you have an occluded coronary artery, entirely occluded coronary artery. And that's a sign that you need to deocclude the artery as soon as possible and as fast as possible. And so to do so, you know, we have either thrombolysis or even better, acute PCI. When you have a non-ST elevation myocardial infarction, most of the time, I say most of the time, not always, you don't have a completely occluded artery, but sometimes it is occluded, but you just don't see it because the ECG doesn't embrace the wide, all the derivation, all the part of the heart. Now, for clinicians, the most important part is it's not the same treatment. STEMI needs to be rushed for the cath lab or to undergo timely thrombolysis. And STEMI, you need to give medicine first, observe the patient, and you only rush them to the cath lab in the most complicated cases. There was another question from the same Alexandru Bot. It said cerebral hemorrhagia includes also ECG changes. That's true. The reverse change in ECG traces provides from vagal mechanism or sympathetic nerves from cardiac plexus. I must admit, this is a tricky question, but one must always remember that they may have ECG changes at the time of cerebral hemorrhage. And it was a huge problem back in the 1990s when we were only performing thrombolysis, because obviously, if the patient has ECG changes and you believe it is a myocardial infarction and you give thrombolysis while the patient is having a hemorrhage in the brain, you may obviously anticipate worst outcome. But this is a tricky question. I would take another question from Zoom physiopathology that asks a very tricky question too. Why do you think clinical trials in the cardioprotection domain kept failing since the basic research was so promising? And I think that's a question for Moana, and that's actually is the major question of my life, I guess. So there are several answers. The first level of answer I would say is maybe. Because preclinical studies are not as smart, maybe, as clinical studies, or they don't have the same constraint. We know how it works. I mean, you're doing the experiment on a mouse, but these days it doesn't work well. You don't have the infarct size you want. It was hot today. It was a very hot day. The cell culture didn't work out, so the results, I can't use them. This is something we always do in the basic science. When you don't have the good conditions, you can't always do everything the same one day to another. So part of the results are not always used. We use the best results to prove our hypothesis, and the statistics are not always performed as seriously as in clinical trials. Who forever anticipates the number of mice before doing the experiment, anticipates the infarct size reduction you want to have before doing the experiments. I do the same. I do just like you. But when you do a clinical trial, you have to do this. You're being asked by the committee, by the ethical committee, tell us what is the anticipated infarct size reduction you want to have. Then you have to calculate the number of patients. You cannot eliminate a patient's results because it didn't work the way you wanted. And the other thing is, in our animal models, most of the time, we use young animals. They don't have diabetes, they don't have hypertension, they don't have dyslipidemia, they're not obese, they don't have all the things that we'll find in our elderly patients when they are being admitted for myocardial infarction. So I would say the preclinical model we use, they're very interesting for us to understand how things work, but it gives you just a photography of one part of the crime scene. But when you have a myocardial infarction in a patient, it's not a photography, it's a movie. You have plenty of scenes and you have plenty of angles to watch the scene. And a paper was written a few years ago that was trying to address the question Luana asked us. Why doesn't it work in patient? And the answer said, maybe we are shooting at moving targets. we are shooting at moving targets. When we do the preclinical experiment in mice or in cells, the target is right in front of us. It's not moving because we identified the target and we're targeting the target. But when you're in a patient, you have plenty of targets. They're moving. You don't have the same target at time 0, at time plus 10 minutes, at time plus 30 minutes, plus 1 day, plus 30 days. And we need to embrace the whole complexity of those targets to maybe, at some point in the end, be able to reduce infarct size in those patients. I hope I answered the question. Do you have any questions on the YouTube?
No, on YouTube, we don't have any questions.
So I have another question on the Q&A.
Yes.
Alexandre Bott said, tall R waves are also a sign for arterial hypertension in left ventricle, even if these waves in lateral precordial leads are a sign for left ventricular hypertrophy. Yes, but this is more like, this is a bit apart from our subject. It's not always easy to interpret an EKG in patients. Usually, tall waves are found in ventricular hypertrophy. If you have a very, very important arterial hypertension, such as in malignant hypertension, you may find this kind of waves. But I must admit, this is quite far from the subject we discussed today, although it is interesting. ECG analysis is a whole story by itself.
Thank you, Denis. Indeed, as you mentioned, this is the major criticism for the experimental models in the preclinical settings, that they are performed in young and healthy animals which are lacking comorbidities. And basically, this is the main topic of this cost action, European Union cardioprotection, which hopefully will be prolonged for an extra 1 year this year because it had to be finished. But Professor Derek Hausenloy, which is coordinating this action, this cost action, strives a lot to have the continuation. And they are designing some experiments in large animal models with comorbidity. And this is a very interesting research area because, of course, you need the animal model to describe the effect of an intervention or of a drug. No patient, there are studies that no patients will accept to be given drugs that have not been tested on animals. So if you make an investigation in this very moment, most probably they will tend to 100% to say, no, I will not take the drug if it was not tested in animal models or in cells. But this is research. This is the fun of research and the beauty of research, because you have to strive and go further beyond the negative results and negative data and look for new hypotheses. And every negative result is also, is in fact a benefit, because you know this is a dead point and you should not go further. So you eliminate one hypothesis, but there are plenty of others.
Yes, and that's why it's so important. When you have, so negative results in humans usually are being published. You mentioned that it was nice for us to publish the negative result of the covert MI trial. Should a result have been positive, we would have been published in the New England Journal of Medicine. No, seriously, that's the only reason we were not taken, because we had neutral results, but the circulation said those results are interesting. They need to be shared with the scientific community. That's what a researcher does. We bring hypotheses, we test the hypotheses, we produce the data, and then you need to share the data to formulate new hypotheses, right? So,
clearly.
And sharing the data is part of our job too. I always insist on my younger colleagues doing the research fellowship in our group to be able to communicate, to share the data, to interpret the data, to criticize the data, and to accept criticism of the data, which is not always easy.
Of course, and this is why, as you mentioned in the beginning, you go from bench to bedside and back, because you see that didn't work. You saw that this didn't work at the bedside, so you have to go for new hypotheses at the bench, which we'll continue to do, of course, and hopefully together. So thank you once again for being with us today, and thank you for sharing your expertise of both positive and negative data, which are equally important. And if there are no further questions, but yes, there is one extra. I see some.
No,
No. It was the thank you from Alexandru.
Dr. But thanked us thanks for the answer. Thank you very much for the questions. And I must thank you for inviting me. A fost plăcere. Mulțumesc mult tot.
Și noi îți mulțumim și te mai așteptăm.
Mulțumim tare mult pentru participarea dumneavoastră în această seară alături de noi. Acestea fiind spuse, până data viitoare, multă sănătate. La revedere!
La revedere!
La revedere și pace, mai ales pe lângă sănătate.
Pace!
Vă dorim tuturor!